Good afternoon, everyone. My name's Richard Jones, Editorial Director of Devex, and I'm delighted to be joined on stage by John Miners, Chief of Mission, Aligned Businesses and Healthcare Solutions at the American Heart Association, as well as Dr. Teri Reynolds, who leads clinical services and systems at the World Health Organization. Teri and John, if you'd like to make your way to the stage, please. And ladies and gentlemen, there's a few seats here in the front rows if you'd like to come forward. Don't be shy. Thanks, John. John and Teri. Great. As you prefer. I think it's fine here. So Teri, John, a warm welcome and a big thank you to the American Heart Association for its support in helping to really power our journalism here in Geneva this week for WHA 76. So John, the World Health Assembly is expected to adopt a new resolution on, and I quote, integrated emergency, critical and operative care for universal health coverage and protection from health emergencies. Could you walk us through the aims of this resolution and why this resolution is so necessary at this time?
Sure, thank you, Richard. And it's a pleasure being here. We're very interested in this topic of acute care and emergency care systems. More than half of mortality in low-resource, low and middle-income countries is from time-sensitive emergencies, and these incidents of trauma and accidents and things that have to be responded to quickly. We take for granted in the developed world that you have a very well-developed, integrated system of well-trained providers, response systems, and emergency call systems that don't exist in their entirety in other parts of the world. So the American Heart Association and others are very interested in helping support the development of that infrastructure. So to me, this initiative is all about that and establishing those systems in low-resource countries.
Thanks, John. And Dr. Teri, as the World Health Organization lead on clinical services and systems, what can you tell us about the current state of acute emergency care in low and middle-income countries? What did the pandemic reveal in terms of gaps in the delivery of these services, and what are some of the main challenges and obstacles that you're currently facing?
So it's a very good question. It's a very big question. There were extraordinary and horrifying things uncovered by the pandemic, even for those of us who thought we had an idea of the gaps in care. So for a long time, we've had a WHO process of doing emergency care system assessments that are really led by ministries where they convene all of their national stakeholders. And we look across the domains of emergency care that we know every country should deliver. So it's their functional domains. Whatever your resource envelope, you should have a way to do ABC. And we found some really extraordinary gaps that people don't expect already before the pandemic. And then in the pandemic, you just saw this more starkly in a way because you saw the consequences of it recorded every day online on your phones, the numbers going up. And then beyond that, these systems, they are the primary, you only get one health system, whether that is for your everyday population health needs or whether that is for emergency response. It's the same health system. And so we saw many things happen at the same time. We saw countries unable to meet the health needs of people who were suffering from COVID-19. And at the same time, it's the same system providing care for children with pneumonia and adults with heart attacks and anyone who has sepsis. And then, of course, injury, which is hovering around 9 to 10% of the burden of disease, the global burden of disease, and more so in some settings. So we saw both of these things, this incredible numbers uncovered of, one ICU bed for 6 million people, entire countries that only had 6 ICU beds. But we also saw the gaps in the continuum of care in the system that was not prepared to respond dynamically and was rapidly overwhelmed. And then even in the countries where the system itself was not overwhelmed, we saw a lot of confusion about care-seeking behavior and people being afraid and not understanding what they needed to do. So essentially, on almost every domain, we saw the gap in a robust emergency critical and operative care continuum. And many people, think of the pandemic around acute care in general or emergency and critical care, but we saw these extraordinary disruptions in essential health services that were not necessarily related to a respiratory virus. So for example, elective surgery was the most disrupted service in the pandemic. And many countries started with a backlog. The high-income countries are getting out of their surgical backlog, but there are now countries that will not get out of their backlog in the lifetime of the people on that list. So either we start doing things differently or we're writing off a generation.
So a sobering state of play. Perhaps I could turn from the state of play to what we can do to actually improve this situation. What are some of the tools, resources that you can share with our audience today in terms of genuinely improving acute care service delivery, particularly in low and middle income country contexts?
Sure, yeah, and accurate's a good word too, because that's actually what it's about, is getting your attention where it needs to be, when it needs to be there. So that's the good news. We actually know how to do this. There are a lot of difficult problems to solve in the world. This is not difficult in terms of knowing what to do. We know exactly what to do. We have a very robust set of, for example, WHO tools. There are other tools, but they address things like training first contact providers to be able to approach syndromes, difficulty in breathing, altered mental status, shock. And those are very simple to use, and any provider can do it. And we have evidence that shows how to train people and how, in such a way that they will immediately be able to execute this effectively. So those are there. The other thing is that we have key process tools. So one of the biggest things you can do is not complex at all. It's not about, the initial gain is huge and not about the infusion of new material resources. So there are key simple processes that have to do with things like early recognition, triage, resuscitation protocols, referral, counter-referral, and those are incredibly low-cost, high-impact interventions, and they can be done anywhere. And we have evidence that shows, for example, organizing a resuscitation space, putting what you do have in one place, making sure everybody knows where it is and how to use it. So those things cost almost nothing, and there are mortality gains, not process gains, mortality gains up to the order of 50% in these conditions for those simple low-cost interventions.
And perhaps I could bring John in on this. What's the role of the American Heart Association here, and how do you plan to collaborate with the WHO and others in this space, and also to tease the fact that you have a special announcement coming up this evening that you may or may not be able to share some details about today?
Sure. Thanks, Richard. I'm often asked, why is the American Heart Association interested in this topic? And it has to do with our legacy in resuscitation, CPR first aid training, if you will. We helped develop that over almost 60 years ago as a discipline, and now expanding it. We do training in over 100 countries around the world for both healthcare providers and lay population. So this is a natural evolution for our organization, and partners like the Laerdal Foundation, who has been an early adopter and interest in this, and also providing, helping us create a coalition of the willing, I guess, interested and willing, and by that I mean bringing both technical and financial resources to help support the work of WHO. As Teri said, it's not knowing what to do, it's the innovation to implement that is still yet to be done, and figuring out ways to scale this work and these tools. That's where the American Heart Association is interested in supporting and enrolling others, right? So we believe we can help bring others that have the same interest as we do, Laerdal Foundation, and we hope to announce a bit of more structure around that and some type of an alliance, coalition of the willing, if you will, tonight.
And so to become bigger than the sum of your collective parts.
Of course.
Well, time is running a little short, but I did want to ask both of you for one key step, initiative, effort in order to ensure impact here. This is something that drives everything that we do at Devex, whether it's in our journalism or our on-stage events. So I'm going to press you for one key step that our audience here in Geneva or watching at home can take, and perhaps one key ask of them as well. So what can the global health, the global development communities, what can they do to support your efforts moving forward? Teri or John? John first.
I'll start. I think the one thing that science has told us in everywhere in the world is that it's a time-sensitive emergency is a chain of survival. And at every point, there needs to be recognition and activation of the system. And every link needs to be strong or the person doesn't survive. So these are things that directly relate to outcomes of survival. And we believe that there's a really high return on investment to implementing these very simple tools and measures, and they can make a real difference in people's lives.
Dr. Teri?
So it's not an easy question if you want one answer for everyone, because you have quite a broad audience at Devex.
It was a tough question.
It's one of your advantages. No, it's just that there's a different answer for each of you. So basically, we want care to get to people, and we want people to get to care. And we have to think about the moment when someone has a problem and the interval between when they have that problem and when they know what WHO department they belong to. So we need to really look at it, first of all, from the person's point of view of someone's happening to you. Then we need structured systems that achieve each of the functions. We know what those functions are. The way that we achieve that depends on who you are. So one thing is, countries, we work for countries, and they have given us a very strong set of orders that are laid out in detail in this resolution. So I won't go through all of those, but there's like 7 categories of very key concrete actions that they ask countries to take and WHO to take. So we will follow that. But what we need to happen is countries need to take a structured approach to identifying the actions that will work in their setting. We have processes to help them do that. They do that very, very well. Second, we take our mandate from those. We've done a frequency analysis of everything countries decided to do. That's how we build tools. So we now have a shared toolkit that anyone can use. That is what WHO actually does well, I think, is that kind of neutrality in common language. So we need those of you who are implementers, we want you to take that toolkit and support countries to implement it in their countries. So at least no matter how many seats we have, universities here, NGOs there, government implementation here, it's around a common content. So that is big. And then finally, those of you who are funders, we want you to join us. We are trying to effectively, and we will be talking about an initiative this evening, to bring people together so that we can stop doing the same thing. And everybody's building the same tools over and over again, the same data collection mechanisms, the same platforms. And that allows you to build the platform, spend $1 million on that, and implement it 5 sites. We want everyone sharing these expensive parts and implementing at 5,000 sites instead of 50. So really it's about joining us and amplifying the impact that we can all have together.
And John, did you want to come in on that final ask of our global development community?
We'll be seeing you soon. That's.
It's great. Well, Teri, John, thank you very much. And to the American Heart Association, I'd like to give a big thanks to you as our partners today. And without further ado, I'd like to hand over to my colleague, Kate Warren, Executive Vice President, Devex. Teri, John, thank you.
Thank you.